Hello, everyone. Welcome. I'm Erica Buswell. I'm the Deputy Director at the Goldfarb Center for Public Affairs. I'm going to get into the camera frame right now. Excuse me. It's part of this welcome. So we are delighted to be co-hosting tonight's event with the Maine Monitor. Just want to tell you a little bit about the Goldfarb Center. We are Colby's hub for politics, policy, and the press. And as part of our work, we convene timely conversations on current affairs and topics that are in the news. So you might be familiar with the event series we've been running the past year called In the News. This is our opportunity to really open it up to the community, invite you all to ask questions and hear the wonderful insights of these panelists and experts who are going to speak with us tonight. Katie.
Hi, I'm Kate Koff. I'm the editor of the Maine Monitor. Thank you again so much for joining us, and thank you to Colby for co-hosting this with us and putting us in this wonderful, beautiful space on a lovely afternoon. For those of you who don't know the Maine Monitor, we are a statewide investigative nonprofit newsroom. All of our work is free to read. We also have kind of an unusual structure where we allow any news organization in Maine or elsewhere to republish any of our work for free. It's part of our mission to really make sure that we are informing Mainers about the issues that matter in their state. And this is another one of the things that we love to do is sort of do these live journalism events where we can bring some of the folks who we talk to over the course of our reporting out in person to see all of you and to share all of their knowledge about their particular subject area. So thank you again so much for coming. And I'm going to turn it over to Rose Lundy, our senior healthcare reporter.
Hi, everybody. Thanks for coming out tonight. As Kate said, I'm Rose. I'm a health reporter with the Maine Monitor, and I'm excited to talk to some experts today about healthcare across the board in our state. So as you may know, we've seen a lot of change and contraction in our healthcare system in recent years. We know that there's been at least 16 nursing homes that have closed since 2020, and roughly half of our hospitals don't have birthing units anymore, and our hospitals have really struggled financially in the year since the pandemic, with Northern Light announcing the closure of its Waterville Hospital next month. So there's been a lot of change and challenge happening. So to give us some more context, we have 4 expert panelists here from really different parts of the healthcare system. So we have Stephen Michaud, who is president of the Maine Hospital Association. And we have Michael Tyler, who is managing partner of the Sandy River company and board chair of the Maine Healthcare Association, which represents nursing homes and assisted living facilities. And then we have Sue Mackey Andrews, who is has been a public health advocate for decades, and especially in rural areas. And then we have Catherine Simmons, who is the let me get this right, Associate Director of Health Programs at the Rue Institute. Okay, so Stephen, let's start with you. I mean, you have kind of a broad perspective through the hospital system here. So could you start by telling us kind of how we like what the pressures are on the current system, how we got to where we are, and in particular, I know the pandemic had a huge impact. So how have we seen that?
Yeah. Is this on? Can you hear me? Thanks. So thank you very much for having all of us, and appreciate the opportunity. So I kind of would start with this. It wouldn't start with the pandemic, but I'll get to it. And it is, I kind of look at it a little bit more globally, and we start with, at least I do, that we are the oldest state in the country, and we are the most rural state in the country. Those 2 factors right there put Maine hospitals in particular, but I think the healthcare field in general, behind the 8 ball right from the get-go. And why is that? Because first of all, that means a lot of Medicare and Medicaid as part of our business. That's not necessarily a bad thing, but they are both poor payers. They don't pay the cost of care, so it aggravates the financial losses that we have and strains the system. Also, because of those factors, though, rural, oldest, we have a caregiver problem. So we have more and more people that need care, fewer people, at least in Maine, to provide the care. We've known this for decades. We said for decades, what are we going to do when the baby boomers retire? Well, guess what? That's where we are. And all of those things that we predicted are coming true, is that it's straining the system. So that's always going to be, it's always been difficult. The other thing about being rural is that we, especially in a state like ours, which is so geographically large and spread out, we have hospitals from Fort Kent to York. And that right there means it's going to be more expensive. You've got more infrastructure. You're trying to spread those costs and that capacity over very few, relatively few people, especially in rural areas. So that just becomes a more difficult thing there. But then the pandemic hits. So we were struggling anyway with all kinds of issues, but the pandemic comes in. We were concerned immediately because you got to remember, right? We shut everything down. So you couldn't even, other than emergencies, we weren't even taking care of people for a bit. But then big federal bailouts came, right? We got a lot of federal money to prop up the system, like so many parts of the economy. And it kept us alive. But it was the pandemic that wouldn't end. You know, we were hoping 2020 would be it, goes well into 22. We come out of the pandemic with our number one problem with our work is what was with our workforce. So we had a burned out workforce. We had people that were retiring. The great retirement occurred for hospitals as well. If you were close to retirement during the pandemic, you were going to take it. And that it left us with a very burned out, strained workforce with a lot of shortages. And that made us dependent on travelers, traveling nurses in particular, in order to provide care. That is very expensive, incredibly expensive, and is a financial backbreaker. So as that federal money kind of dried up, understandably, in terms of COVID bailouts, if you will, we were left with raging inflation, like everybody was, 9% inflation, big workforce shortages, trying to chase salaries and benefits in order to recruit and retain people. And then we still had an inordinate amount of travelers, which is just a financial backbreaker. I'll give you one piece of data and then I'll hit pause. So we entered the pandemic, you know, using travelers. We always use them to some extent. And then, of course, right at the peak of the pandemic, it peaked. The use of travelers and the cost, the numbers and the cost. Post-pandemic, we came down, didn't use as many travelers and the cost eased, but we settled at 50% more traveler costs than we did entering the pandemic, and we remain there. So that is just one factor among many that is aggravating the financial status of Maine hospitals right now.
Just a quick question on that. I'm curious. I mean, is that just the difficulty of getting people to come back into the work? You still have to rely on travelers?
Well, so there is to a degree, but we lost a lot of people. And of course, when we reopened, it took a while, but we had a surge of demand as well. And so it takes a while. You know, you don't just train a nurse, for instance, you know, it takes years in order to develop and recruit and retain and educate people to fill these jobs. So we're behind the 8 ball on our staffing. And so that is one of the reasons that we still use travelers. Now, again, it's nowhere near like it was peak pandemic, but we settle at what I call an artificially high rate that is still straining the system. But that, again, I could go on and on. I'm trying to make sure that there's other airtime, but that's only one component of what's going on. You know, don't get me started on commercial health insurance companies and what they're doing to us. Drug costs, I could go on and on. But
yeah. And kind of in line with what you were talking about, the financial pressures, we've seen, especially this year, that there's been funding constraints and challenges at both kind of the state and the federal level. Can you start by talking first about kind of where things stand with MaineCare reimbursement right now, and then also what potential Medicaid cuts could mean for hospitals?
So, overlaying all of our, the problems that we're having. So we've got a state budget and a problem and a federal budget problem. So the state budget is kind of the more urgent one because they need to deal with this here in the next month or month and a half. And there is a very large cut to what we call hospital-based physicians, but it's essentially for physician services that are provided in the hospital under the Medicaid program. That's in the governor's budget, and it is big in the second year of the budget. We are vehemently opposed to it and are doing everything we can to get rid of that cut, but that is looming over us, among other things, in that budget. So that's the most urgent issue in front of us right now. And the reason is because of the timing, meaning the federal government, isn't going to be resolved here in the next month, what is being proposed there. So we are looking at potentially large cuts at the federal level as well. We got a glimpse this week into what we could be looking at. It's been a moving target. There's a whole host of proposals that range from literally catastrophic to, big problems. Let's put it that way. And it's a whole range of issues. So we saw in the House, they're debating it, dealing with it in a committee right now in the U.S. House. Proposals that I will say could be worse for us. They could be far worse, but are still problematic. And we just don't have a number on it yet because it's been moving around in terms of what the proposals are, but it's an all hands on deck to try to prevent those as well. At a minimum, a lot of people will lose coverage under Medicaid. Again, we were fearing something far worse than what is at least kicking around right now, but it's a major concern of ours because the number they are trying to achieve, whatever it is, they lowered it. It's not $850 billion now, it's lower. It's still just mammoth, and there's only, as they know, as Senator Collins in particular said, there's no way you're getting $800 billion out of, that budget, that area of the budget and not emaciating Medicaid. And that's what we're looking at. So, yeah.
Thank you. Yeah, I want to turn now to Catherine. Perhaps, so we've talked about some of the challenges that we've seen, broad scopes in hospitals and the contraction we've seen across the state. I wonder if you could talk about how we've seen those challenges specific to maternal care in our state.
Maternity care is a microcosm, hospital-based maternity care is a microcosm of what was just raised about hospitals. I think a few things that are really important. The health workforce is a huge issue. And hospital-based maternity care is very expensive because you don't know when people are going to come in labor or with a complication. Therefore, you have to be prepared at all times, 24/7, with a fully skilled team. And the team includes skilled nurses. They know how to handle a delivery. Somebody with the ability to do a cesarean section in case there's a complication. That might be an OBGYN, it might be a family practice physician. It could even be a generalist surgeon, but you need an advanced clinician to be there for the delivery with the nurse and then somebody who can do a C-section. Which means you also need an anesthesiologist. You need a pediatrician, somebody who can handle, because even if it's a family physician who has obstetric skills, they can't be handling the baby, the neonate, and the pregnant delivering person at the same time. So you need a whole team of people prepared. And back to this issue of we're the oldest state in the nation, right? So we've been having a declining birth rate really since the 1950s. And Maine, we are just not producing a lot of babies, and even more so in rural areas. The places where we're seeing, more babies being born are in southern Maine, and the northern reaches and more rural areas are just having these declines. So you have a hospital unit that has been experiencing declines in birth, needs to keep a fully trained staff ready for anything that comes through the door. And they need to keep their skills up. So when you're only seeing, maybe if you're lucky, 20 births a month, or not lucky, but if that is your volume, which is high for some of the hospitals in rural Maine, that's not a lot to go around for all of your clinical staff. Some are seeing a few births a month, and those are the ones that really have faced these questions about whether to stay open or not. And then it comes back to the financing, right? How do you keep this very expensive unit that has high stakes around the care of the people who are coming in, babies and mothers nobody wants to see anybody die or have serious complications. So it's very expensive. Also, rural people receive Medicaid at higher rates than urban people, and Medicaid rates are not good payers and or not equivalent payers in terms of parity. So all of those pieces come together for this perfect storm of it's really hard to keep maternity units open in rural Maine and rural America. This is not a unique problem to Maine. However, we're experiencing it among the worst in the country. We've lost 4 birth units this year alone. And that is because we are the oldest state. So all of those issues come back around and really make the maternity care in hospitals an acute crisis, really, we're facing right now.
Yeah, I'm struck by if this is a trend that's been happening since the 50s. I mean, do you expect that to change at all? And if not, if it's not going to change, then what do we do about that going forward?
It's a good question. The birth rate in rural Maine is probably going to continue to decline unless we start to build communities that are attractive to families and young families, people who are thinking about having children. And there's a little bit of a double-edged sword there, right? If you don't have places that people can have their babies, raise their kids, send them to school, have robust opportunities for them, people are not going to move there. So we did some research at the RU with rural hospital health workforce, specifically around the health workforce of maternity units. And we talked to people, providers, clinicians, administrators at all of the hospitals that had open birth units. One of their challenges around recruitment was they might have a really terrific OBGYN who they're ready to sign, who says, but there's nothing here for my wife to do. Or we can't find a house. Things that are just basic to creating the right secret sauce to recruit, retain, build that talent, and keep it in those communities. So I think until we start really coming up with innovative, community-based opportunities for people to bring their whole family, it's a challenge. We're going to continue to have to hire travelers or face these really difficult decisions around closing units.
Yeah, that's interesting. A lot of the conversations I have with health experts, they start with talking about access to healthcare, and then it turns into, transportation and housing and workforce shortage, and it just kind of unravels into all these other little streams that are all interconnected, it seems like.
I can say more about other solutions, but I don't want to, we can come back to that or
Well, let's hear some solutions.
Okay.
Yeah.
Well, okay. So one thing is we did receive, here's a bright spot. Maine received a grant for the Transforming Maternal Health Initiative, which is through the Centers for Medicaid and Medicare. And it's basically an innovation grant. And we were awarded $17 million. They call this TEMA. And that initiative, we just received it in January. So there is a lot bundled into that $17 million 10-year grant, which is to start to really address some of these really deep challenges through systems change, really thinking about regionalization, which is a necessary part of how we solve this problem. So really, instead of every hospital thinking about its local community, we have to start thinking about regions and thinking about how do we centralize care so that everybody doesn't have to travel too far to get to a hospital where they could have a baby. And also, what are the other supports? People go into delivery pregnant, right? You've got 9 months, if you're lucky, to prepare. So you can identify the people who are high risk and might need to be transferred, have their baby in a more high level maternity unit where there's a neonatal intensive care unit. There are some people who can have local baby, have their babies locally because they're low risk, they're healthy, they come into pregnancy, and really you only need to make sure that there's good emergency transport in case something unpredicted happens. So the TEMA grant has some of that built into it. They're also going to be looking at what's called value-based care, which is a different approach to reimbursement. Instead of fee for service, which is how we construct our healthcare system currently, it's really thinking about population and outcomes for a group of people instead of individuals. And you start to build ways of reimbursing that are rewarding, health, people going into pregnancy healthy, people having prenatal care, people getting postpartum care, all the times that there might be complications, instead of having people show up at emergency rooms really sick or in labor, really not healthy. You're building in ways to check on them by having doulas, for example, who can do home visits, provide psychiatric mental health care, because postpartum depression is a real thing that can really sabotage the health of a whole family. So those are some of the activities that are happening through that grant. And there's a lot of work happening through the Department of Health and Human Services coordinating around that. And then I've been doing work with the Rural Maternity Obstetrics Management Strategies Group, which is another rural-focused organization that is an award that came through the Health Resources Services Administration. And so there's a lot of initiatives happening, especially around psychiatric mental health during pregnancy, other ways to get people healthier before they have their baby and during the postpartum period. So there are bright spots. There's a lot of good work happening, but we definitely need more.
And the work on those grants has already started?
Our Moms grant is actually in its last year, although I believe they are going to be continuing through some private support. But the federal funding for that will be ending, which is going to be a challenge.
Great. I want to turn now to Mike. In a lot of ways, aging care in Maine has the opposite problem that Catherine just was talking about, which is that the demand is quite high and is increasing, and we're already the oldest state, and by a lot of metrics, we're only getting older. And so I wondered if you could talk about the challenges that you've seen specific to aging care in Maine.
Thanks. I mean, a lot of what you've already heard, it's all interrelated. Staffing and labor issues are probably number one. There actually have been 50 long-term care facilities closed in Maine in the last 10 years. And I would venture to guess that most, if not all of them, are related to the inability to staff. In addition to that, we have a lot of facilities within the state that have units closed, and they're down on capacity, and not because there isn't need. There's plenty of need. There just aren't plenty of employees. So when that happens, and when you can't fill positions, and you have the inability to bring people into facilities, what happens then is they're stuck in the hospitals. Okay. And we're seeing that. And I spend a lot of time talking with folks from the Maine health system and from Northern Lights. And there are a lot of folks in the hospital today that shouldn't be there. They should be in a long-term care facility. And what then happens is that if I need elective surgery, all right, I can't get it, or I have to wait 8 months to get an elective surgery done. So it is all interrelated. And it is by far our biggest challenge is all around labor. We said we're the oldest state in the country. Well, that creates two issues. One, it's to care for us older folks. I was the youngest person in the room when I first started in this field. I'm not anymore. I've been involved with long-term care for 40 years. I started in the acute care world. But it also creates a scenario where our workforce is also one of the oldest in the country. So, what do you do about it, right? I kind of land on something that's a little related. It's housing. I believe that in the state of Maine, our biggest problem to solving a lot of our issues, not just healthcare, is affordable housing. I'm not talking about subsidized housing. I'm talking about affordable, significant increase in affordable housing. If people can't afford to live here, how can we expect to increase the workforce? It's impossible. So I think a push has to go to creating an environment and a housing environment where people can live here. It's a great place to live. I'm from Maine. I've lived here my whole life. I've lived in Washington County, Hancock County, Aroostook County, all over the state, okay? And it really is the way life should be. But if you can't afford it, okay, how can we increase our workforce? So I think there's a real relationship between what goes on and the problems in acute care and the problems in long-term care. I would say, since I've been involved, in this a long time, we have a really solid long-term care system in Maine. It is mature. Historically, compared to other states, it's been incredibly strong. But there are a lot of weaknesses or attacks in certain area because, if funding isn't significant, you can't run a facility if it's only running at 70% occupancy because you can't staff it. Very challenging. But I'm always, those that know me, I'm always up for working on solutions and collaborating. And, I think there's ways to do it, but everybody has to want to work together and listen to little bits of the truth, right? It isn't just one thing. So I appreciate the opportunity. I mean, I've been involved with it a long time. I think, it's not going to be solved quickly, but we need more affordable housing. And it can't be impossible to develop it, right? It can't take 4 years to do a project. We don't have that kind of time. Thanks.
Yeah, I wonder too. I mean, like we already have an old population that there's a lot of demand for, and there's the challenges that you talked about. And we know that it's going to the demand is only going to increase. And so I wonder if you have any thoughts on solutions or what planning we should be doing right now at the state level to try to address that growing need.
I mean, I think Steve mentioned it, and, you know, this isn't a surprise. Demographically, we knew this was coming. Okay. I would think, you know, part of the answer is planning and collaboration. And today, I think there's very little real planning going on statewide. There are some really good organizations, you know, that are doing good work, but, you know, this planning honestly should have been done 5, 10 years ago, not right now, but you got to start. If you wanted to sort of rewind this to probably, I think it was 15 years ago, I was on not a panel, but I was part of a commission to deal with a labor shortage in the state of Maine with Mike Mishu, Norm Ludwig, and the head of the community college system. And if you pulled that report out from back then, you'd thought I had written it yesterday. Okay. The same issues, but no one has done anything. So, yes, I mean, let's dive in, let's collaborate, let's, you know, both at the Department of Human Services and with other organizations, let's work on this together, but let's get moving because, you know, I don't think I'm going to do this forever, you know. And I'm not the youngest guy in the room anymore. And, but yeah, there's almost no, in my opinion, not much planning is being done, but execution is the key. I don't want to study it. I want to study it and then do something.
Yeah, I wanted to ask you if planning meant another commission.
Well, you do need to do the work, but I want to really do the work, not just talk about it. And Mainers know that, you know, let's do something. Let's just not talk about it. And, you know, I'm up for being in the middle of it because I'm not shy. Why not be part of a solution? Okay, as opposed to just complain.
Absolutely. Well, thank you. And now I want to turn to Sue because I think so. Sue has a perspective from as a public health perspective and in a rural area, and I think all of these issues really kind of come to roost when you're in a really rural area. And so I wondered if you could talk about how you see the impact of all of this change in rural Maine.
It's pretty significant. I am fortunate to be a volunteer facilitator for our local coalition, which also serves as the crisis response team for our region, meeting sometimes every week during the wintertime and every other week during the summertime. So new to us since COVID has been the increasing numbers of homeless people. And so I just want to impress upon people that this is so circular. And we've all been talking a little bit about it, but we have, on any given day, we can have 50 to 60% of the staff at our hospital, which is the Northern Light. We have 2 critical access hospitals, very small, both Northern Light affiliated. But at any given day, 50 to 60% of the staff on the floor, in the lab, et cetera, are travelers. So what do you do with travelers when they come to rural Maine? You find them housing. So the first thing that happened was they took all the motels, and if you've been to Piscataquis County, you know we don't have a lot of them. So what happened was a couple of hundred houses were sold, renovated into Airbnbs, and which are accommodated to the travelers, which also then reduced the rental housing market in our region. So now we have homeless families, we have homeless people, and today I dealt with a 74-year-old man with significant diabetes who is homeless, has been homeless since October, 74 years old. So it's happening not just in our region, not just in our county, but it's happening everywhere. And you cannot just look at this through one lens. You have to look at it through the collective. And in our region, we're often referred to, Piscataquis County is referred to as the oldest, poorest, and most sick region, which is true. Our maternal child health statistics are the worst in the state, and we work on that. We have more elderly than we have young people by more than 10%. So we have no replacement factor for the workforce, and the work that they would do has changed dramatically. So there's no more mills anymore, a lot of part-time, very low-wage jobs. It's not uncommon for people in our region to be working 2 and 3 jobs. I can't underestimate or understate the significance of what's happening. More sick people, and the mental health issues that have erupted, anxiety, depression, suicidal ideation, et cetera, across our youth and across our older population, including our seniors, is substantial. And on any one day, you can go into our hospital and at least 6 of the beds will be taken by somebody in mental health crisis, a youth or another person, because there's no other place to send them. So that's reducing the number of beds for the kind of surgical or other needs that we might have. And the access to services, we are a county with no state services located within our boundary. Everything comes up to us from Bangor or over from Waterville. So people are coming into our county to serve a population that lives in a culture, a very rural culture, a very different culture. There's only 17,000 people in Piscataquis County. We live in a place where you can literally say with truth, everybody knows everybody. Just the changes are dramatic. People are sicker. They're sicker earlier. And the hospital just cannot accommodate what they need. And plus, enrollment in Medicaid and Medicare is quite high in our region. I would say that probably the hospital receipts are 65 to 70% Medicaid, Medicare, which isn't paying the cost, as was earlier stated. So they're not making it at all. And they weren't making it before the what some people call merger and other people call the takeover of our local hospitals by Northern Light. So, and you can always tell how people feel about it from their single word, right?
Yeah, and the state just released its community health needs assessment report, and yeah, I wondered if there were any kind of major takeaways from that you flagged when you were looking at it.
You know, we've been working with the Maine CDC on this project since its inception, and the first year that they produced this report, probably I think this is the 5th report that was just released. All of the regions, health districts were merged into one summary, which was not helpful when we're in the same district as Penobscot County. So you couldn't even see Piscataquis in the metrics. We were very successful in the second year to have them break that out for us. So we are able to look at our own metrics. When we do the forums every couple of years, we're able to get more people with lived experience who actually live in the region to come to the forums and contribute. So we've watched over time, over these 5 cycles, our whole needs assessment change, become more real of what the needs are in our region. Our concerns about our youth. I mean, over a quarter of our kids have very high ACEs, 4 or more. And I would mention of very significant importance, poverty is not measured in the adverse childhood experience scale, right? And yet we know that that is the biggest driver of the outcomes for children. So most of our kids are living in poverty to some degree, some more so than others. And for the first time since the pandemic, we're now seeing homeless kids. We have a program with Penquist called the Homeless Host Program, where we have kids placed with friends and neighbors in the community so they can finish high school, but there aren't enough placements for all the homeless kids. You know, so it's the dramatic impact of COVID on an already stressed system is really profound. And some days it's kind of hard to get out of bed and go look at it, actually.
Is there anything that's making you feel hopeful about the future, or any kind of solutions that you think could help address some of those problems?
Well, yes. We have a very dynamic voluntary coalition that's been around for 27 years now. And we've grown into the role that fills the gaps that other people aren't there to perform. We've started meeting every other month to talk about housing, to talk about transportation. We've worked really hard with Penquist to improve their transportation system. We're looking now at housing. How do we grow housing that is affordable, that's safe, that meets the criteria? This is one of the problems. Our county, Piscataquis, is one of 881 frontier counties in the country. So that means there's 6 or fewer residents per square mile. So it is not sufficient, it is not economic, it's not real to have buses running all over Piscataquis County picking people up. It doesn't work. We have to find other ways. But it makes it very challenging to get services to people or to get people to services. That's our second. Housing is now our number one challenge. And this is probably true of other places. Transportation, second. Access to meaningful, good wage jobs is third. And that was reconfirmed through the shared China.
I'm going to ask one more question to all the panels, and then I'll turn it over to the audience for questions. So start thinking about your questions. And I think if you're on Zoom, you can submit them in the chat as well. So feel free to start sending those in. But to everybody on the panel, if you could change one thing about the health system today, no matter how big and ambitious it would be, but if you could just wave a wand and change it, what would you pick and why? I guess I'll start at the far end.
I'm glad you gave us a little preview of that question because it kept me up last night. I was like, what is my one thing I have a big one and a more reasonable one. My big one is everybody in the United States wakes up and says, everyone deserves health care. Could we just get back to that? So that's if I really had a magic wand, a powerful magic wand. And I guess on a more practical level, it would be, and this is still a big one, right, is reimbursement, that we would have parity in reimbursement around, Medicaid and Medicare so that people who need those ways of paying for their health care can get it, and that the providers who are providing that care are seen for the work they do and justly paid. Those are my answers.
Yeah.
We're working on an initiative now that really seeks to hire 5 community health outreach workers for our region that would be placed in each of the 5 major community gathering spots. The service communities, if you will. And these are folks who would be well-trained and supervised. They could be high school level people, bachelor's level people. They don't have to have much more training or education than that, but would be going out into the homes of folks who get referred, would be doing case finding, and would be able to do that comprehensive case management from the living room with people. I get really romantic when I think about when I moved to Piscataquis County. We still had doctors making home visits. We still had doctors making home visits. We had a doctor, I was in pediatrics at the time. We still had a doctor who would see any kid that I needed him to see at no charge if they didn't have a primary care provider. I would love to have those days back. They're not coming. I know that. I can still be romantic about it, though. But I think there's a future for community health workers. And I think they should be funded. I think they should be reimbursed by public and private insurance. And I think everybody should have one. Old people should have somebody visiting them, and I'm one of those old people, on a regular basis just to make sure I'm okay. People who see patients in their office don't know what the living room and the kitchen and the bathroom look like. Somebody needs to know with eyes on what the safety issues are. Do they have running water? Do they have plumbing? Do they have electricity? Do they have a place to sleep? Those become the very critical issues, I think, to ensure that people are safe and well cared for.
So you'd like to see a broader use of community health work?
I think it's our future, frankly. I don't think we're going to grow a lot of more doctors and nurses overnight, but we could grow CHWs and we have a pretty elaborate design, and we're working with a couple of funders now to take a look at how we could make this happen. I think it's our only recourse, truthfully.
Mike?
One thing is really hard in an interconnected world. Mine's kind of similar to my friend on the end, which is that I would really like to see statewide our population and everyone realize that what we're providing, the services we're providing are essential. They're like law enforcement, they're like fire. They are essential services. They're not optional. And so that, there's a realization that if that's true, then they have to be funded. We have to be clever to figure out how to afford them, agreed, but we can't close our doors 2 days a week. Our services are essential. And sort of a realization about that. And our population saying, enough. Okay, these services are essential. Okay, and speak up. That's really what I'd say. And then if I could really snap my fingers, okay, and all of a sudden something would be changed, there'd be a lot more affordable housing in Maine, a lot more. And I honestly believe that that would go a long ways to resolving not just healthcare related labor issues, a lot of labor related issues. That's my 2 cents or more.
Stephen?
Yeah, like Mike said, it's an impossible question, right? But I appreciate it because it makes you think because there are just so many things, right? This system and how we got into this mess. Look, there is no easy answer, right? And if you think there is, that's a big mistake. There just isn't. There isn't one answer. But what I would do is dramatically increase, and I mean dramatically increase, investment in primary care. And the reason for that is, to explain that a little, because there's all kinds of things you could do. But first of all, that whole area of the healthcare system is rapidly decaying, for one thing, and it has huge implications for people. And then if you've noticed over the years, if you go to your primary care doc, if you can get one, if you can get in, if you notice this you got 15 minutes and he or she's got their hand on the door or their face into a computer. And that isn't that practitioner's fault. We are driving them to do that. We, the greater we, because of money. And so we're doing it. I admit it. The hospitals and health systems are driving more and more because you've got to be efficient. And we are taxing physicians out of their profession. I don't mean taxing money. I mean taxing their mental health and physical health. And it's not sustainable. And it's also, importantly, not healthcare. You cannot be treating holistically an individual in 15-minute bursts. What they're doing is you go in, what's your problem? Here's a prescription. Here's do a lab. And that's not healthcare. And so what I would do is do that, focusing on prevention and disease management. And you not only get better care, I'm literally this is so wishful thinking right now, but better care for the individual, better for the physicians and the health practitioners. And also, it's the only way to start getting your hands around the problem with affordability. We can't eat, drink, smoke, do whatever we want, and then just go to the doctor for 15 minutes, get a script, and think that's healthcare and that we're not part of the problem. So we've got to change that equation. We can't be, exploding in obesity and then complain about healthcare costs. So that's why I focus on that. You start to, if you'd have to be king for a day, or queen for a day, but you start to get at the core problems that are driving access problems, cost problems, problems with the patient themselves. So that's what I would do.
So if you focus on prevention, then you can reduce the expensive costs of later disease.
Right, but prevention is only a component of it, because that's hugely important. But also, when people do get disease, they need to manage it better. People that with their practitioners manage it better. There's a lot of money that can be saved. You look at, the 80-20 rule is alive and well in healthcare, right? 80% of the money is spent on 20% of the people. That data is in Medicaid. It's everywhere. And so I always go, well, like the guy that robbed banks, don't you go where the money is? So there's a lot of money in sick people with chronic diseases, multiple diseases. So it's disease management and definitely prevention, but getting back to really primary care physicians and nurse practitioners and PAs providing healthcare, not the mill that we're doing right now. Not this, that's what it's a treadmill. And you're just moving in and out, in and out, in and out, room to room. That's not healthcare. And so that it would take a massive investment, by the way. And I know that, but that's what I would do if I had the wand.
Maybe someday we can put all of these into practice. Okay, I'll turn to the audience now. And I know we have actually a couple of experts in the audience. So I don't know if David from Maine Care wanted to share your thoughts.
Thank you. My name is David Jolly, and I am on the board of Maine Care. Some of you may know us. We are a state-based organization that advocates for universal health care. And we currently have before the legislature a bill, the All Maine Health Act, which would, if adopted, implement our plan for universal health care here in Maine. And I was at the public hearing for that bill this afternoon. And I would encourage all of you to take a look at that plan. I wish I had brought copies of our summary, but I was rushing here and forgot them. But I wanted to just sort of follow up on some of the points that you folks had made. As healthcare costs continue to increase, healthcare quality and accessibility continue to deteriorate. We at Maine Care believe that it is way past time for a major transformation in our healthcare system. And we think that incremental approaches, which we have been implementing for decades, just aren't going to get us where we need to be. We're kicking the can down the road. At best, they're going to postpone. They're not going to prevent the eventual collapse of our healthcare system. Why aren't incremental changes enough? Because they don't address the fundamental problem with our healthcare system, which is its domination by corporate entities whose primary goal is profit, not quality patient care. Those entities include, first and foremost, private health insurance industry, but also big pharma, for-profit hospitals, and even some nonprofit hospitals, which are increasingly operating as if they were for-profit hospitals. So we've developed this plan. It's a publicly funded, state-based plan for universal health care in Maine. We'd prefer to see it at the federal level, but that ain't going to happen anytime soon. So we've spent the last couple of years, along with 20 organizations in 21 other states, working on state-based approaches to universal health care. It worked in Canada. Canada's national health insurance plan began in one province, Saskatchewan, back in the 60s. It was so successful that within 5 years, every other province had adopted it. It could happen in America as well. And probably the question you're asking is, how could we possibly afford it? And the revenue sources for our plan include a health tax on individuals that would be based on income level, and a tax on businesses based either on total payroll or number of employees. But there are substantial savings in our program that come from moving us towards a single payer system that would dramatically reduce the exorbitant administrative costs that are associated with private health insurance, especially billing and reimbursement costs. We did a fiscal analysis of our plan that indicates that those administrative savings would be sufficient to provide coverage for the more than 80,000 Mainers who are currently without any health insurance at all, and more than several hundred thousand more Mainers who are underinsured, meaning that they have health insurance, but they still can't afford health care because of ridiculously high deductibles and copays. So that is a nutshell where we are. I'd be happy to talk with people more about the All Maine Health Plan. And I think it addresses a bunch of the points that you were making in terms of, if I could change just one thing, this would move us towards accomplishing, I think you named 8, and I think it would move us towards 5 of those. So thank you very much.
Thanks. Does anybody on the panel have thoughts on universal healthcare? No? The sooner the better, you said? Okay. We also have the Maine Medical Association here. Did you want to share some thoughts on the discussion?
My name is Scott Hansen. I'm the president of the Maine Medical Association. Thanks very much, Rose, and the folks at Colby Goldfarb Center for putting this on. As the physicians and surgeons of Maine and our nurse practitioner colleagues and PA colleagues, many of us have those sorts of professionals in our practices every day. We know where the problems are, and we would love to keep working with all the folks that are represented here, but especially with the people of Maine who need to tell our elected representatives, especially now, that enough is enough. The system is broken. It's not working for anybody. It's not working for the nurses who can't afford to live where they want to live and work at a hospital and deliver babies or whatever it might be. And the problem is not that there isn't. Yes, it's about affordability, but we're spending twice as much as every other country in the world to get worse outcomes. So just follow the money. I think Steve might have mentioned it. It's about money. There is, I'm not going to say plenty of money, but there is enough money in our healthcare system in 2025 to fix the problems that we're talking about if you get it back from the profiteering insurance companies, mostly, that waste and administrative stuff. It hits my members in our offices just as much as it hits a big hospital or a corporation that has to figure out their payroll and pay insurance. We struggle just as much to get paid as you do. So there's pieces of single payer healthcare regionalization that make a whole lot of sense because there's just so much waste in that multiple payers with multiple, and the big thing. So you asked for one big thing. I'm going to come up with 2. The first is the Medicaid crisis is a crisis. Medicaid drives everything. It's the floor. If you don't get paid enough for a delivery or for taking care of sick kids or for whatever you're doing at your nursing home population has about 30 or 40% of people are relying on Medicaid/Maine Care to be able to stay in that facility. So if Maine Care goes out of business, which it's in the process of doing both short-term and long-term, so the Maine Medical Association is fighting with the hospitals and with any other institution that knows that money matters, both in Augusta and in Washington, D.C. We want our 4 federal legislators to keep fighting for us, and they're doing as well as they can. So Medicaid needs to be funded going forward as a floor. But the other thing is much more specific, but many of you in this room may have experienced it. It's that prior authorization scam that's going on by United Healthcare and other entities, including, unfortunately, some clinical collaborators, I'm going to call them, who are hiding behind utilization review and medical necessity and blah, 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 to delay, deny, and then defend. And that's been going on for 15 years. It just happened to hit the news a little more recently, and that was a terrible tragedy, but it's true. The money that is being sucked up into profiteering and shareholders' benefits by United and Anthem Elevance and Cigna and Aetna and all the rest of them, that's where the money is. We need to take that back. We could start by banning prior authorization so that hospitals get paid and surgeons get paid for doing the work they need to do instead of just generating profits for insurance companies. I've already spoken probably too much, but please know that your nurses and doctors and surgeons and physicians want to help fix this problem so we can stay here too and live in Maine. One last thing I'm going to say, I wrote down work and live in Maine because at our retreat just a few weeks ago, the MMA board, we decided we're going to work with the state agency that's responsible for people, not just to come here and eat lobster in the summer or ski at wherever, but to come and live and work with us. Remember that ad when you fly into to Portland? You could be living here, not just coming for vacation. I forget what the buzzword was, and we want work and live in Maine to be the first place that healthcare professionals go when they want to bring their family to Maine and work with us, because we need all the help we can get. And I think we can outcompete a lot of other states with our amazing lifestyle, our beautiful settings, the fact at least we're growing a little bit compared to some of the other New England states and certainly some of the other rural places in the country. We are growing. It's slow, yes. We're growing with new Mainers. We're growing with people that come here during COVID. And you know what? It's not so bad up there. So I'm hoping that we can keep working with the nursing homes and the nurse practitioners and maternity folks, the midwives. I can't forget the midwives. They're a big part of this solution. And that's going to be, I believe, a good place to start, recruiting people to come here and work and bring us patients to take care of. Thanks.
Great. Thanks, Scott. Do we have any other questions from the audience? Does anybody have a question?
Thank you, Erica. I'm Wally Bushman. I'm retired as an attorney in Waterville. Anyway, it's kind of the chicken and the egg situation. I look around this room. What are we missing? I see maybe 1, 2, 3 people who are young, relatively speaking. 4. I'm sorry, 4. Anyway, we don't have a model that brings people to the state. How many times do you see people who say, I love your state. I'd love to be there. Why aren't you here? What are the opportunities? How many of us have children that we've raised, have done very well, gone to Colby, gone to Bowdoin, and they leave? When the Gold-Farb Center had the Commissioner of Human Services come and speak, she made a pitch to the Colby students. Maine, think about it. We have opportunities here. As you were saying, they're here. The population may be growing, but we haven't grown very much from 1900 when we had about 1 million people here. And what do we got? 1.3 million now, 1.4 million, something like that? Universal health. I think it's the best thing you could have. I'm all for it. I'm all for cutting out all the middlemen and all the other things that take place here, but it's one thing to come up with an idea of how we're going to solve the medical crisis We can't do it until we can start getting young people to want to stay here. I mean, we need to, a meeting like this, we need to be inviting as many people as we can. High school students, you mentioned having a high school student possibly on the committee to deal with things. You'd be surprised how involved they can be. I'm just reading a book now about a 15-year-old girl who was did a science project that became the model that was used for the pandemic. It's amazing. You can tap into a lot of people out there, have a lot of ideas. You've got to reach the young people who want to be here. Many of them don't want to leave the state, but we've got to create opportunities. And you're right, housing. I don't know how you feel and deal with it. The Airbnbs that are coming along, taking up a lot of the housing because they make more money on it. But you're right, affordable housing is needed and critical. So I just my thoughts on it. As I sat there and I looked around, I said, Neil and Neil are very young here. I know they're, but it's important for us to reach the young people in the state and make it a desirable thing for them to want to be here. I mean, it's a big picture. It's not just how we meet medical expenses. It's the whole thing we got to look at. Thank you.
Yeah.
Thanks, sir.
Oh, yeah.
Hi there. Hi, everybody. I'm Kate O'Halloran from Life Flight of Maine. How many of you know about Life Flight of Maine? Show of hands. How many of you know someone, family, friend, coworker who's been transported by Life Flight of Maine? And so, you know, I thank you for having this. And I guess the question is, and I'm so proud to work at Life Flight because we are doing some interesting things. For anybody who knows me, I push boundaries. And we're doing that at Life Flight. There's a mental health care crisis among healthcare workers. And we, for the first time, we have embedded a clinical care clinician at Life Flight who will see all of our, including our pilots, which is pretty taboo, and our clinicians free of charge for as much as they need. And she's been here a year and she's seen more than a third of our workforce confidentially. We're also doing things like we have a mortgage program. And when we go to recruit, we give them a package about here's your mortgage banker, here's your real estate. So we help them come. We give them education and tuition, and we're trying to get people to come to Maine. But I think the thing that keeps me up at night is what is going to be the tipping point? You know, I, like a lot of you, grew up here in Waterville, and we had 3 emergency rooms, right? We had the osteopathic and Thayer and Seton. And we, Life Flight, we used to transport, you know, a person every 3.5 hours. We were in Waterville 3 times on Sunday, 3 times. We're transporting 16 and 18 people in a 24-hour period. And the reimbursements, not helping. It's tough. So I guess the question is like, what is the tipping point? Because I'm really worried, and I'm really worried about Central Maine. And I think it's actually an interesting thing because things are going to get very real here in Central Maine very quickly. And I think it might be good for the state because it's going to be a wake-up call. This is not, you know, Presque Isle, where I'll be tomorrow night talking about Life Flight. This is Central Maine. And I think it's going to get very real. So what is the tipping point going to be, in your opinion?
So I don't know what the tipping point is, but I want to say thank you because I'm here because of Life Flight. I wouldn't be here without Life Flight. They saved my life. I was 30 days at Maine Med. I died twice. So I'm here because of that. I wish I knew, you know, what the tipping point was going to be. It's a really, you know, we just went through a pandemic, right? And you would have thought that might have brought people together, wouldn't you? I thought it might, but it didn't. How soon we forget. I wish I knew. I mean, I think a bigger public push in terms of we've had enough. Okay, and we're going to talk about this, and we're not going to take no for an answer, and it has to be a lot of young people involved too. I agree with what you said, but anyway, I just wanted to say thank you. So,
Oh, yeah.
I don't, obviously, nobody knows what the tipping point is. I will say this, after been in this field for decades, we are rapidly deteriorating in a way that we have never seen before. So, meaning just what you heard, what you've seen about rural OB, inland closing is one hospital, but it's a little bit of a harbinger. Look at the losses, not the number of hospitals losing money, but the shocking losses, the amount of money Northern Light has lost. Look at what's happening in Lewiston. St. Mary's was, not that long ago, a 200-bed hospital. It's got 17 med-surg beds. And then harping on earlier about primary care, it is, as I say, inartfully, I say it, it's circling the drain very, very rapidly. So whatever that tipping point is, I've never seen us kind of careening to it as quickly. The only thing a little cold water on how quickly things will move is the division in the country. If you think we're close to universal health care, we couldn't be farther from universal health care. Mike just mentioned the pandemic. We look what the pandemic uniting us, it divided us even more, right? Vaccines, masks, it's a hoax. It isn't a hoax. It actually made the divide worse. So you look at the division in the country, which has never been more. You think you're getting universal health care anytime soon? I'm afraid you're not. I think we've got to go through a lot more pain before we get to that tipping point. And it's going to be ugly, unfortunately. But rural OB, last thing I'll say is rural OB is a great example of how quickly something can spiral out of control. And the impact on moms and families in rural areas, there is no OB between Presque Isle and Bangor now. I mean, you can't wrap your head around that in some ways. So this can go quickly, unfortunately, but in the wrong direction.
So I do want to echo that. And I think in some ways we have seen the tipping point where I live. And the most common thing I hear, especially from the older folks or the people who live in deep poverty, is, well, I'll get used to going without whatever it is. And they get used to going without most recently electricity, because this is the season when we turn everybody's electricity off. They get used to going without clean water or running water or plumbing facilities. And I hate to talk about this publicly because I feel like a third world country, and I know that we're not the only county that is facing this. But I don't know if you folks know about ALICE. How many of you have heard about ALICE families? So these are asset limited, income constrained, employed people. They're the people who marginally make over what the eligibilities are for various public supports. You can go on any United Way website and you can see this data very granularly by town. You take the poverty level by town, which is publicly available, and the ALICE level by town. In our major communities in our service area, which are Dexter and Dover Foxcroft, that percentage of people living in poverty or near poverty is over 70%. So that means you're driving around in a community where 3/4 of the people don't have enough to pay the bills or eat or get health care or much of anything else. And the problem is that they're getting used to it. And somehow they don't believe that they deserve anything better. How tragic, how tragically sad. And you're right about the division of COVID. We live in a very, I call it conservative faux region. I've had many conversations with people who are receiving multiple public benefits and still don't want to pay taxes. Well, they don't pay taxes, but they don't understand how things work. They don't understand that their Medicaid card is a federally funded program, that their SNAP benefits are a federally funded program, that their VA benefits are a federally funded none of this. Their housing subsidy is a federally funded program. And I don't know how you educate people about that. I've tried, and it's like, I might as well talk to the flag on the wall. It's very difficult, but it has divided us. And we had the lowest vaccine rate despite we would go into business places and vaccinate everybody who was in there who wanted it. It just was so politically charged. And we're still dealing with COVID. We still have COVID admissions and COVID deaths. I don't know. This concerns me. Because when apathy erodes, everything, I don't know how you build it back, truthfully.
My favorite sign ever was "Get government out of my Medicare." Yeah, that's.
Did you want to?
I have to share 3 bright spots because I agree with all of it. I feel so sad when I hear all of these things. But because I'm at the Rue Institute, a few bright spots that I have seen. One is, if you may not even know about the Rue Institute, but it was David Rue's vision that Maine really needed to build some alternative pathways for economic opportunity for the state. And because his experience is in tech, he partnered with Northeastern University, founded the Rue Institute. And so I have met so many students, they're graduate programs only currently, so many students who have come back to Maine because they said, now there's a program here where I can study what I wanted to study, and that they had not seen it in Maine before. And the hope is that we can create the economic pipelines, the opportunities in jobs that they can actually stay. And so we have a whole entrepreneur founders residency program that is building startups that will be located in Maine. So that's one bright spot. Lots of I grew up in Maine, went away to go to college, have now come back for this graduate program. The other bright spot is I have been doing some work with the New Mainer Resource Center, which, the obstacles for foreign trained physicians and nurses to become providers here in the US are ridiculously insurmountable. And there are models. Massachusetts has actually streamlined the process because they are also, believe it or not, having problems with recruiting and retaining providers. So there's work beginning in Maine, and we recently hosted an event with the New Mainer Resource Center around internationally trained foreign medical graduates about how could we start to really model some of this or streamline some of this process in Maine, because they want to work. They need to do residencies. They need English language proficiency, and that's part of, getting them into the provider. They want to live and raise their families here. They have resettled. And they're talented and their experiences are deep. So that's another bright spot. And then the third is actually something that we have started, which we call the Gap Year Program, which is a program for post-baccalaureate aspiring to become clinicians. So we don't care what they want to be. They might want to become a physician assistant, a nurse, an occupational therapist, but they have indicated they want to do something like that, but they need experience. And so we were lucky to get a Department of Labor grant that was allowed us to start this pilot program where we give them $500 a month in addition to the salary that they get for taking an entry-level position in a healthcare partner. So we work with Maine Health and Northern Light. We work with federally qualified health centers, and we place students. Interestingly, a lot of them are Bowdoin, Bates, Colby, UMaine grads, and then we are also bringing them in from out of state. And there's a lot of interest, and people are like, never thought of Maine before. And now we have, our first cohort is done. We're just wrapping up the second cohort, and one is going to the Tufts Maine Med track. One is at UNE, one went to USM for nursing. So we're seeing really positive results of the exposure and the networking and the socialization into Maine is a great place to live and work. And so I just wanted to add that so we're not all sad tonight.
Yeah. There was an interesting question from Zoom, kind of speaking of solutions, and so Kat wondered if there might be if rural healthcare could look to the example of bookmobiles taking services on the road. Does anyone have any thoughts on that?
Been doing a lot of work with the Maine Mobile Health Program and also with Knox Clinic in Knox County, which we were able to gift them a mobile health unit. And there are many other programs around the state that are starting. The Healthy Community Coalition in Farmington has a mobile health unit. I think actually in Portland, the I forget their name, Access Health has one. A lot of them are organized around social determinants of health. So they're not necessarily doing primary care, but they're going out and making connections with people in the community around social needs that they have. So some bring food, some bring clothing, some do social service navigation, some will do harm reduction, vaccinations. The one that we're rigging out for the Knox Clinic will eventually do primary care as well. But that is definitely part of the solution is, community health workers, primary care providers, mobile health units and telehealth. So innovative ways of bringing care to people in the communities where they live instead of having them have to travel, because we know transportation's a barrier, right? And the cost of gas and having a working car and all of those things that keep people from going to primary care.
I know we have just a few more minutes, so I might try to get through some of these quickly. So Robert asked if you could talk about the impact of EMR and whether this has forced too much charting as opposed to human contact. I assume that's for hospitals.
Sure, yeah, probably the number one aggravation for physicians is electronic medical records. And the great promise was, it was going to make us all more efficient and safe and all that. And it just hasn't lived up to it. I caution, though, and say, can you imagine going back to paper? I mean, we're not going back to paper, right? So we've got to make those work better than they do. But it is a big component of the aggravation factor and why your practitioner is staring at a screen instead of you. Yeah.
We're not going back to paper.
We're not going back to paper.
Anne asked, how do the long-term care workers' salaries compare to other Northeast states? Don't know if you know that off the top of your head, or maybe Angela knows.
I couldn't quote exactly where we stand. I know that generally Maine's labor rates are lower, than a lot of other New England states, not just in assisted living and nursing homes everywhere. I'd venture to guess that is the case. And, we know why to a certain extent. I mean, you got hospitals trying to stay afloat. You have long-term care facilities trying to, stay afloat and, cover the losses, right, that we have on the Maine Care and the Medicare side of things, which don't cover cost. So I couldn't quote exactly, but I'm sure we are not up to snuff. But you also have to then increase payment if you want to, if you want to pay more. It's an equation, right? It's math. So, yeah.
Any more? You want that?
The state is very different.
Yes, I mean, at least on the nursing home side, on Medicaid, it's different in every state. Every state's Medicaid program is different. Medicare is generally the same, although there is some, there are Medicare C plans, there's some demonstration programs. But as a general rule, Medicare is the same, Medicaid's different everywhere.
And we decided to make it confusing here and call our Medicaid program Maine Care. So when we talk about Maine Care, we're talking about Medicaid. Angela, did you have anything to add on that? Or Angela's the Executive Director of the Maine Healthcare Association.
Thanks, Rose. Hi, everyone. My name's Angela. So just in response to the comment about wages. So I think Stephen mentioned sort of the state Medicaid hole, right? So there's presently $118 million shortfall in the state Medicaid or Maine Care budget. Those dollars are waiting to be allocated, right? We talk about policy and politics. And so those monies won't be allocated probably until the end of June. And then also when we talk about caregivers' wages, cost of living increases, right? Being able to keep up with inflation. We talked about lack of affordable housing here tonight. And so when providers' rates, it doesn't matter what kind of healthcare you're delivering, when the Medicaid rate that is paid to you as the provider isn't adjusted year over year for things like inflation, how do you pass on a meaningful cost of living increase to your workers? And we know that if we can't do that, right, we struggle with workforce recruitment and retention. That's a huge issue. And in our state budget, policymakers have cut cost of living increases across the board, zero, nada, none. So at a time when we don't have enough workers to start with, the people that we are electing to represent us at the state level, right, haven't figured that out yet. And it's not to say that it's an easy problem. It's not an easy nut to crack when you have a state budget that's in the hole. And we have a lot of people on Maine Care, right? We know that during COVID, enrollment was frozen. That was for a good reason. We didn't want to kick people out of Maine Care because of eligibility problems. And so our enrollment is very high. And that is also causing a lot of conversation about how do you fix that going forward? Raising taxes or revenue generation tactics, those get people's hair standing up. They have very difficult problems to solve. And then, our fine panelists tonight have also talked about the federal budget problem. I mean, we don't know what that's going to look like for long-term care. And I think Stephen used the word catastrophic. It could be, right? We pray that it's not going to be, that people are going to make reasonable and sensible cuts. But if the federal dollars that come into our state stop flowing or are dramatically reduced, what is that going to do? It will further constrict access to these very vital services. And you had a brilliant question about what's the tipping point. We've seen over 50 long-term care facilities close in Maine. We are the oldest state in the country, right? And we know that our over 70% of people over age 75, 70% are going to need some kind of long-term care support and service at some point in their life, whether they can age safely at home, whether they're going to need some assisted living, home care, nursing home care, or hospice. I don't know who's going to be there to take care of them. I really don't. And by the time I get there, I don't know either. So we have to fix it, and I think to Mike Tyler's point about collaboration and planning, we don't need another commission. What we need are angry people in this room to stand up and do something about it. So I urge you to get involved.
Well, on that note, I think we are just about at time. So I think we'll wrap it up there. And thank you to all our panelists for coming out tonight. Thanks for everybody here. And thanks to Colby for partnering with us. So.